Recording going to Fausta?
Yep, it just started.
Awesome.
Okay. Let's just make sure this is working. There we go. All right. Hi, everyone. Thank you all for joining. My name is Fausta Ferzoko, and I'm a second-year physiotherapy student from McMaster University. Tonight, we're going to be talking about pediatric vestibular rehabilitation, which basically means how we treat kids with different types of dizziness. Okay, just a little intro here. So I'm currently doing my clinical placement at B3 Therapy in Brantford with physiotherapist Haley, who is a registered physio. She's also a vestibular therapist and clinic owner.
Thanks. Great. We've had Fausta the 7 of 7, and she's been learning lots about vestibular rehab, not only in pediatrics, but also in adults. So we're looking forward to seeing what she has to say today, and teaching, I know, me a few things and teaching all of you. So, and just a note, if you have any questions, please drop them in the chat. We're just going to leave the Q&A at the end, but feel free to do it there and let us know if you have any technical difficulties. We're here.
Yeah. Okay. All right, so just to give us a quick overview of tonight's webinar, we will start by going over the vestibular system. Then we will talk about vestibular rehabilitation for kids, including what you can expect in an assessment and a treatment. And then we're going to go into some specifics and research on a few common conditions. And finally, we'll end off with time to answer some questions. So again, please feel free to post in the chat if anything comes up, and we'll get to them at the end. Okay, so before we get started, can I see who is familiar with the vestibular system? So feel free to use the thumbs up function under reactions, and I'll give you all a second to do that. Okay. So we're going to be talking a lot about this system tonight. The vestibular system is found in the inner ear and is actually the first sensory system to develop in humans. It provides our brain with information on our movement and head position. A child's life revolves around movement, basically anything you can think of, whether that be crawling, running, jumping, riding a bike, or playing sports. These can all be difficult tasks for a child with a dysfunctional vestibular system, which is why the vestibular system is important to consider for children, as it plays a key role in gross motor skill acquisition, like learning how to sit, stand, walk, or run, as well as postural control development. The vestibular labyrinth, pictured here, is an important piece of anatomy to talk about. It's fully formed by the 49th day of pregnancy, so pretty early on, but its connections with the brainstem are not functional until 8 to 9 months. It's located in the inner ear and is composed of 3 semicircular canals and otolith organs, including the utricle and the saccule. The semicircular canals are depicted here beside the stars. There are 3 in total: posterior in the back, anterior in the front, and lateral, which means horizontal. These canals detect rotational head movements, like shaking your head yes or no. The otolith detect linear movements. Specifically, the saccule, depicted here, detects movement in the vertical plane, like going up or down in an elevator. And the utricle detects movements in the horizontal plane, like moving forwards or backwards in a car. So utricle, forwards and backwards, saccule, up and down. And then the nerves, shown here, carry this information to the brain, which helps us maintain posture, balance, and gaze. Signs and symptoms. I know this slide looks a little overwhelming. There are a lot, but vestibular dysfunction is actually harder to recognize in children, as it can be difficult for them to describe or even understand what they're experiencing. They may simply avoid activities or cry when something is uncomfortable or challenging. Identification of these disorders takes some teamwork between the child, parents, and us healthcare workers. Signs and symptoms may include dizziness, nausea, motion sickness or sensitivity, clumsiness, poor posture, ear pressure, headaches, developmental and reflex delays, which we'll get into more later, visual acuity problems, so difficulty seeing clearly, poor spatial relationships, which can be seen by skipping words or letters while reading or having disorganized writing, nystagmus, which is abnormal eye movements, hearing loss, or tinnitus, which is ringing in the ears. Each child's signs and symptoms will depend on where the dysfunction is coming from. So if it's peripheral, involving the organs in the inner ear that we talked about, or if it's something central, so involving the brain and brainstem, as well if it's one or both ears that are affected. Today we'll be focusing on concussion, benign paroxysmal positional vertigo, or BPPV, which I'll be calling from now on, motion sickness, and gross motor delay. So what is vestibular rehab? Vestibular rehabilitation is a specialized form of physiotherapy for those who are experiencing vestibular disorders. The goals of VRT are often to reduce symptom intensity and frequency, improve balance, and increase activity. Vestibular assessments usually involve many components, which we'll get into in more detail, but we'll go through subjective assessment, a neuroscreen, range of motion, oculomotor screen, balance testing, and positional vestibular testing. So now we'll get into what you can expect. We always like to start by taking a comprehensive medical history. So this includes questions about symptom intensity and frequency, triggering movements and activities, and symptom alleviators. So what things make these symptoms better? Children with vestibular conditions often use atypical descriptors for the dizziness. For example, a child might say they feel wibbly wobbly or like they're on a roller coaster. As well, it's important to ask about the patient's hearing and vision status. For pediatrics specifically, we must ask parents about their child's motor milestones and birth history, as these answers can help us understand why they're experiencing vestibular dysfunction and also how we can help. Other components of the assessment include a neuroscreen for any red flags that may need further assessment, as well as neck range of motion, so having the child look in different directions, as this is a common area to be affected with a vestibular condition. So here are just examples of what we would look for. So looking at reflexes, finger to nose test for a neuroscreen, as well as having the child look in those different directions. Next, we'll see how the eyes are moving and if any of these tests reproduce symptoms. Infrared goggles can be used to help us get a better look at the eye movements. So here's an image of the ones we like to use in clinic and how they're worn. They attach to a computer, which allows us to video what the eyes do during these positional tests. So it's really cool, very detailed look at the eyes and very informative.
Sorry to interrupt, Fausta. Can you just mute everyone? We're getting some background noise.
For sure. Let me figure out how to do that.
Yeah.
Let's see.
I think if you go to the bottom of your screen and your mute button, then you might be able to.
Sorry, it just looks a little weird now because I'm under viewing. Let's see.
Or if everyone can just mute, it sounds like it's a little better now. We're just getting some background noise. I'll just
Thanks, everyone.
Oh, perfect. No more noise. Sounds good. Thanks, everyone.
Okay, perfect. Okay, so next we'll talk about an oculomotor screen and what we can expect with that. So we like to look at smooth pursuits, which test the ability to follow a slow moving target. So for example, like this. And then up and down. And then we'll look at saccades, which test the ability of the eyes to move quickly between targets. So like this. Convergence, which measures the ability to view a near target without double vision. So we have the patient bring their fingers slowly into their nose and then stop where they see double. Then we would take a measurement, and we're also watching to see if one of the eyes kind of drifts to the side during that test. And then the visual motion sensitivity test. This will be positive and reproduce symptoms in children with motion sickness. And that looks something like this. So moving to the side with your arms quickly. And then the last one that we'll look at is the vestibulo-ocular reflex test, or the VOR, which assesses the ability to stabilize vision as the head moves. So this reflex actually activates our eye muscles to keep the eyes still during head movements. And children with vestibular dysfunction may not be able to use the VOR to keep their eyes stable during quick head movements, which occur frequently during daily activities, especially as a child. So this test is important as most kids won't realize this is even happening, since most likely they haven't experienced normal vision with head movement. So we can actually try this one together. Warning, this may cause some dizziness. But what I'd like you to do for VOR is hold out your thumb in front of you, so at an arm's length, and keep your thumb in focus. So try to look at your thumb. And then we're just going to move our head side to side at a quick pace while we look at our thumb. So this is also can be turned into a treatment if it reproduces symptoms on assessment. As well, impairment in saccadic eye movements can cause difficulties at school related to reading and note-taking. So that was that looking quickly between 2 points. So thus, it's important to treat kids with these vestibular symptoms in order to prevent challenges at school. These tests will help us understand if the patient's eyes are contributing to their symptoms and also give us valuable information to guide treatment. For balance testing, we'll measure how long the child can balance in a variety of positions and on foam. So this can help us understand how the patient's able to integrate information from their vestibular system, so from the inner ear, the visual system, so from the eyes, and then proprioception, which is the information we get about where we are in space from our muscles and joints. So we'll look at tandem balance and walking, which is 1 foot in front of the other, and then single leg stance, so balancing on 1 foot. And then we always look at on foam, on flat ground, and then with eyes open and closed to kind of tell us how those systems are working together or not working well together. Okay, so positional vestibular testing with infrared goggles that we showed earlier may be used if an issue with the inner ear crystals like BPPV is suspected. This will allow us to analyze eye movements as the physiotherapist moves the patient quickly into these different positions, and that'll help us determine which canal the crystal has actually moved into. So we like to use the Dix Hall pike, which is showed in the photo here, or the supine head roll, depending on which canal we think is affected. And again, this will just help us tailor our treatment. So for treatment, evidence shows that children with vestibular disorders respond well to vestibular rehab therapy. Children have a high level of neuroplasticity, which means that their brains can adapt and modify quicker than adults. As well, children tend to be less fearful of movement, and they're motivated to engage in VRT, especially when we make the activities fun. So VRT uses exercises to address difficulties with eye coordination, balance, and symptoms noticed on assessment. Activities must be based on meaningful and relevant goals to promote treatment adherence. For pediatrics, these exercises will be specifically tailored to the child's interests while being age appropriate. So for example, a visual maze like shown in the top photo here, or an obstacle course like in this photo with the kid jumping on the foam, would be used maybe for like a 10-year-old, while the use of blocks or balls during a balance activity would be more appropriate for a 5-year-old. So in the photo with the basketball, you can get a child to practice their single leg stance. And then as they get better, they can start rolling the ball or holding with their foot off the ball. So definitely trying to make it fun for kids. There are 3 theories of neuroplasticity that are commonly used for treatment, which are adaptation, habituation, and substitution. Adaptation involves exercises to improve gaze stability, balance, and symptom provocation from head movements. Habituation involves repeated exposure to a movement that would typically increase symptoms in order to retrain the brain and reduce that response. And then lastly, alternative strategies are taught for substitution. So, for example, training the other systems involved in balance to substitute for a less functional vestibular system. And we'll get into some examples as we get into the research. So basically, any activity we use in clinic will be taught to the child and their caregiver so that the exercises can be completed at home and included in the child's daily life. We also like to incorporate activities that you can try with your kid at the park, like going on the swings or down a slide to stimulate the vestibular system. Now we will discuss some common conditions and current research on how vestibular rehab can help. Concussion. A concussion is a mild traumatic brain injury caused by a direct or indirect hit to the head. Each concussion is unique. We like to say they're like snowflakes, and presents with several symptoms, often including dizziness. The greatest reported incidence of concussion is actually in adolescents. However, the true incidence in children is hard to determine as many go untreated. While most concussions improve after 1 or 2 weeks, there is growing evidence to support that children are the most at risk for prolonged recovery. So those symptoms kind of hanging around longer than we'd like. This can be evident through increased days of missed school, frequent headaches, and behavioral changes. A recent Canadian study showed that 58.5% of children remain symptomatic after the first month following concussion, 11% after 3 months, and 2.3% after 1 year. So pretty common to have those prolonged symptoms. Interestingly, vision and vestibular dysfunction are common following a concussion and are associated with prolonged recovery times. Research from Story et al. Supports the use of vestibular rehab for pediatric concussion patients. On assessment, most patients out of 109 included reported dizziness, headaches, problems with balance and vision, and they experienced symptom provocation with saccades, so those quick eye movements, as well as abnormal convergence, so basically doubling at a distance farther than we would expect. Those who completed vestibular rehab had a significantly lower overall symptom burden. As well, their balance was substantially improved, which was measured using the balance error scoring system, or the BEST test, as you may know it. Therefore, this research shows that many kids who experience a concussion will experience vestibular symptoms and can benefit from vestibular therapy. Benign paroxysmal positional vertigo will be our next topic, BPPV. I know it's a mouthful. It's a disorder where the crystals in the inner ear are displaced into one or more of the semicircular canals, which causes short episodes of severe dizziness with certain head positions. Has anyone ever heard of BPPV or know anyone with this condition? Please use the raise hand function to let me know. Okay. So a couple people here. Oh, okay, 4. Nice, good to know. So although BPPV is most commonly thought of as a condition occurring in adults, a recent multi-center study showed that pediatric BPPV may not be as rare as we think. 5% of the cases of pediatric dizziness included in the study were found to be results of this disorder. So in this photo here, you can see the otoconia, which are the crystals I keep referring to. And basically what happens is that they can be moved for some reason into one of these canals. So the posterior, the anterior, or the horizontal. Research from Brodsky et al. Supports the diagnosis of BPPV in children using the same positional test for adults. So the Dix-Hallpike and the supine head roll that we talked about earlier. Similar to the adult population, the posterior canal, so that one in the back, was the most frequently affected. This study also showed that repositioning maneuvers, which try to move these displaced crystals back to their original spot, were an effective treatment for BPPV, with 40% of patients needing only one repositioning maneuver. However, these maneuvers can be distressing to children, as the physiotherapist has to move them quickly into the specific positionings. So it's recommended to perform these maneuvers while the child sits in their parent's lap. So as the physiotherapist, you actually move the child with their parent. Interestingly, this research also showed that 80% of BPPV cases were secondary to a triggering event, such as a traumatic brain injury like concussion that we talked about, surgery, or even migraines. As well, a high proportion of cases that experience multiple canal involvement or canal conversion, meaning that the crystal started in one canal and then they actually moved into a different canal, had participated in gymnastics, swimming, diving, or dancing. So just some specific populations we should keep in mind. Overall, this research shows that BPPV in children is more common than previously thought, and it also provides support for the inclusion of these positional tests in our assessment of kids with dizziness. I'm sure most of you have heard of motion sickness or have experienced it yourselves. One last time, can I see a show of hands if you've ever experienced this before? Okay. So a good number of you guys. So motion sickness is actually an intolerance to movement. It's usually experienced in moving vehicles or even elevators that causes nausea, headaches, sweating, and vomiting. This condition is thought to be due to a sensory conflict between your visual, proprioceptive, and vestibular system, which are those important systems we talked about for balance. Studies show that motion sickness is most common in children, and from what we've seen frequently in clinic, many people who experience motion sickness as children also experience some form of vestibular dysfunction as an adult. This may be explained by research that hypothesizes that motion sickness is a result of an immature or dysfunctional vestibular system and likely influenced by hormonal fluctuations. So if you have a kid who experiences motion sickness, it might be worth it to see how a vestibular therapist could help and also prevent future issues. In clinic, we also noticed that women are more commonly affected by vestibular disorders than men. A 2021 study, including 192 participants between the ages of 8 and 11 years old, parallels this observation, but in pediatrics, as it showed that girls were more susceptible to motion sickness than boys. The motion sickness questionnaire short form was completed by each child in the study, which involves answering questions about how triggering environments and stimuli make them sick and how often this occurs. Almost 90% of the children included in their sample reported symptoms consistent with motion sickness, so pretty common in children. The total mean score for this assessment for girls was 2.73 times higher than boys, meaning that girls experience symptoms of motion sickness more frequently. Okay, so motion sickness can greatly affect someone's quality of life, making it important to target through vestibular rehab. There are several strategies we like to use here at B3 Therapy that involve adaptation and habituation theories. One example is the use of optokinetic videos to gradually increase tolerance to movement. So here's an example of a video that we might use in clinic. So basically we get the child to watch this video, and it's not playing right now, but basically it's a video of someone driving up a hill. And what we want is to gradually increase symptom tolerance by actually provoking symptoms a little bit and then having the child stop, take a break, allow their symptoms to come back to baseline before repeating. This will help train the brain to adapt to these stimuli. We like to say what makes you a little dizzy makes you better. Oh, now it's playing. Okay, so in this video, you can just see an example of a car driving through the streets. And this is something we could try in clinic, see how they do, and then also prescribe to try at home. Okay, gross motor delay. A gross motor delay is a term used when kids don't meet their gross motor skills, their milestones within the expected timeframes. Vestibular hypofunction may be noticed in these children. As we know, balance is often impaired for children with vestibular hypofunction, which can make it harder to reach these higher level gross motor skills. Pediatric vestibular dysfunction can slow the development of equilibrium and protective reflexes that are important for movement, motion tolerance, and posture. For example, these children are more likely to be delayed in independent sitting, standing, and walking. They're also likely to fall more frequently than expected. In this photo here, we can see a common assessment tool used by physios to track motor milestones. So it just gives us a good idea of how the patient is progressing, and we can actually track change over time. Research from Bryan et al. Supports the use of vestibular rehabilitation for children with bilateral vestibular hypofunction, so both ears affected, as well as gross motor delays. Treatment involved activities based on coordination and balance. After 12 weeks, the group that received vestibular rehab showed improved gross motor function, which can be measured using the Peabody Developmental Motor Scale. So if you're noticing your kid is struggling to reach their motor milestones, it may be worth it to see a physiotherapist and check how their vestibular system may be contributing. Similar strategies can actually be used here in clinic to work on coordination and balance. For example, we can have a child practice single leg balance with beanbags, like in the photo presented here. Or we could practice tandem stance, so one foot in front of the other, and have them catch a ball or turn to look at cards that are set up around the room. Again, just trying to provoke those symptoms a bit and work on any of those skills that we notice are behind. In summary, the vestibular system is key to consider in children that present with dizziness or troubles balancing. The research presented today shows that vestibular dysfunction is common following a concussion. Kids are more likely to experience prolonged concussion recovery. BPPV in kids is less rare than previously thought. Girls tend to be more affected by motion sickness. Many adults with vestibular dysfunction also had motion sickness as a kid. Vestibular hypofunction can make it difficult to reach motor milestones. And finally, what I really want you guys to get out of this webinar is that vestibular rehab can be an effective treatment option for children with concussions, BPPV, motion sickness, or gross motor delay. And finally, if you love learning as much as we do or are curious about tinnitus, which is that ringing in the ears, feel free to tune into an Instagram live between physiotherapist Haley here and a local naturopath, Dr. Alexis Cole, for their next topic. They've been doing these lives every second Thursday of the month at 9:30 a.m. since the summer, and they choose a new topic each month. All right, so thank you all for listening, and I hope you enjoyed learning about vestibular rehab for kids with me. Please feel free to follow B3 Therapy on their socials or ask me and Haley any questions you might have. I've also included our emails on this slide, so if anything comes up later, you can go ahead and email me. Thank you, guys.
Awesome. Great job, Fausta. So much good information. Does anyone have any questions while we have you here? Feel free to drop it in the chat or feel free to pop on. We're not shy, so feel free to ask us anything. Did everyone know that BPPV could occur in children? Ooh, here's a good question. So do you have any examples of the habituation exercise, Fausta?
Right. So one that we like to get patients to not avoid is those head movements. So if someone is fearful of turning their head to the left because that provokes their dizziness associated with BPPV, that is actually something we'll get them to do. So like we talked about, a little bit of dizziness is okay. So we actually want to reproduce those symptoms a little bit. We always say like a 2 to 3 out of 10 is okay. And then symptoms should settle down within like 20 minutes. And then have them repeat those motions just a few times a day to get their brain comfortable and retrain them to that movement. So habituation is a lot about a little bit of symptom provocation and then retraining the brain. And with a child, you can make that more fun instead of just turning your head. Like I said, you could like set up cards along the wall and be like, oh, where's the dog? And then they have to turn their head to like look at the card of the dog or something like that, just to make it more fun. Yeah. Thanks, Leo. Any other questions? Hmm. That's interesting. I know that some kids on like the autism spectrum are sensory seeking. I'm not sure if that's related to the vestibular symptom. I would think that they probably like the sensation, like the motion. I know that for a lot of kids that gives them like a sense of like anxiety relief, or just provides them a lot of comfort. So they're looking for those like sensory cues because it helps them like relieve other sensations that are like stronger, if that makes sense.
Mhm. Yeah, and I would say, yeah, similar things. They're very sensory seeking, and it can be
Mhm.
very specific because it could be like a oversensitivity. So it all very depends on like each child. Yeah. And Shelly's an OT from out west. So yeah, many kids who never get dizzy. And I feel like that's the hard part too, is that you may not know with kids on the spectrum, depending on if they are verbal or nonverbal, they may not be able to
Right.
also verbalize if they do have any dizziness. So that they may not be able to express that we're having dizziness. So that would be my concern. My question would be, if they're not able to express it, do we know if they're actually getting dizziness? But if we see some other dysfunction, say with their visual system or with their balance or proprioceptive system, that could be an indication that the vestibular system is off as well, or like we
That's
do
a,
in clinic,
that's a
Fausta.
good point.
Yeah.
Do you mind if I talk? Because I'm
Not at all. Go for it, Shelley.
That's a great point, because I've seen so many kids with vestibular dysfunction and
Mhm.
on both sides of the spectrum.
Yeah.
So, and I was going to say, I loved your list. Great presentation, first of all.
Yeah.
And I was going to add to the symptoms of kids, the biggest one I see is avoidance of movement.
Yeah.
So a lot of
Right.
the kids won't say they're dizzy because they don't know what dizzy is. They've never experienced anything else.
Mhm.
It's like a kid never had glasses, doesn't know they can't see well, right? So I
Exactly.
find
Absolutely.
they'll usually be avoidant of movement and things
Yeah.
like swimming lessons. They won't put their face in the water, or they won't turn their head.
Mhm.
You just see it in real life so strongly, these kids who have that
Mhm.
fear of movement. But I think it's just that the people around them, the teachers and families, don't really know why. They just
Mhm.
say, oh, they avoid movement,
Mhm.
and so then, like you say, getting the kids moving and playing is exactly what they need to do, move and play. But I do see the extremes
Yeah.
of the kids who seek, like they literally stand on their head. They literally turn in circles, right?
Mhm.
So I was just curious, like, and not like, I mean, I've seen tons of them, but I'm like, oh, what is the actual cause of that? Do they just have no awareness of like, what is their vestibular system doing that it's seeking that much movement?
Mhm.
Right.
Yeah, it'd be interesting, Shelley. I don't know that research off the top of my head, but I would be interested to see, is it coming from like their brain, like the neural connection, or is it something that they're compensating
Yeah,
for, like a poor proprioceptive system, or something that like they need more of those extreme movements to trigger? So that's a great point. I'd be
yeah.
interested to look more.
Yeah, I know I've learned some of that in one of my courses, but I will look into that for you and get back to you on the cause of
Mhm.
that.
Sure.
But
Thank
And
you.
like Haley was
it
saying,
is, yeah, go ahead.
oh, I was gonna say, like Haley was saying, I think that's also why it's so important for kids, like to not just rely on like the subjective part. Like, even though it's great to like hear them and like ask them questions directly, I think it's also really good to like do all the other components too. So like look at the eye movements, test their balance to give us a better understanding of like that vestibular dysfunction and where it could be coming from.
I love that. I think it works so great, you guys working with teams and who observe the kid, like say in school, say
Yeah.
they never turn their head to look or things like that. And then you guys can do the testing in clinic. I think it's wonderful coordination. Good job.
Thanks, Shelley. All right. And it looks like we've got another question there, Fausta.
Mhm. So the anxiety with treating BPPV or just post BPPV?
Can you expand on that? Expand on that for us, Laura? Post.
Not sure what that is.
Mm-hmm. Yeah, that's not something that's super common there, Laura. So
Hmm. Haley, do you know?
I haven't heard of that.
Yeah, same.
Okay, it's drop attacks. Okay, drop attacks. So a person falls to the
Okay.
ground with no warning. Okay, so interesting. Yeah, there could be. So with the drop attacks, that would be my question would be, so if the drop attacks, did they hit their head? Could it be some of like a neck dysfunction going along with that that could be contributing to some symptoms or throwing off the vestibular system? Or then again, crystals could break off for that. And Laura, do you mean more the anxiety of you worrying about your little one with a 10-year-old, or is it something that your 10-year-old is experiencing anxiety? Because I'm sure it's both. In that situation, it would definitely be, I know I would be nervous about my little one having some post BPPV the other day. So it is super normal for anxiety to happen after having BPPV. It's the falling sensation from sitting up after the second treatment. Oh, okay. So there's some falling sensation. That is super normal. Is that dizziness and that sensation of feeling like they're falling or that your vestibular system is off kilter. I know things that I will do with clients, and Costa has done with like our clients as well, is just even grounding, breathing, slow movements, feeling the sensory system around you. So feeling what the table's feeling like, holding on to parents, if that would be something that would be super helpful, or even what something that I'll do naturally is just put my hands on the client's shoulders just to try to ground them and focus on their breathing or feel my hands. That can be super helpful as well. Just to kind of settle those anxiety symptoms, because it can recreate a little bit of symptoms, not necessarily the vertigo that goes with BPPV, but it can significantly cause quite a bit of anxiety.
Yeah.
I hope that answers your question, Laura. Anything to add, Fausta?
Just like what you were talking about with the deep breathing, like with kids, I like the technique of them like focusing on their breath and then like trailing up and down their hand, like just more like tactile cues, even like just deep breathing with like a hand on the chest and the stomach, just so they feel that like they feel really grounded with that, like that extra sensation. That's what I would just add. Yeah.
Absolutely. Looks like we've got them from Cheryl here. So Cheryl's another vestibular physiotherapist. Could be the lack of feeling grounded. They don't provide that sense well. So movement provides an increased sensation to the vestibular and proprioception. Yeah, that's a good point. And especially to the point of feeling grounded, it could be like if your central nervous system is ramped up and we're always in that constant like fight or flight, or that autonomic nervous system is out of whack, which basically means you're kind of living in that high stress state. If they're not feeling grounded, that could be, I would think that could definitely contribute to it as well. All right. And then Daniela's question.
Yeah.
Do we use the DVA in kids?
I have seen research when I was doing this project to support the use of the dynamic visual acuity test for kids. So I think it can be used as like another component to include an assessment.
Absolutely. And Daniela, the DVA looks at dynamic visual acuity, but it's also kind of and goes hand in hand with the vestibular ocular reflex, right? So it's the ability to read something while you're focusing on that target. So it's definitely something that I would look at as well with pediatrics, and I have with some of my pediatric concussion clients as well. And it looks like Shelly is chatting with Cheryl there. It's truly poor interoception there for kids. There are usually other senses these kids seek because of the hyposensitivity. They need to feel more. Yeah, and it's just when our sensory systems are out of whack, right? So if you have, so say someone with like hypersensitivity versus hyposensitivity. So someone who is very hypersensitive is not going to feel great when they have lots of layers on, or if the visual environment's super overstimulating, or if say even just not feeling grounded where you are. So the sensory integration is crazy. And if something's off, or say if someone is having difficulty seeing or having a lot of say light sensitivity with migraines or with concussion, or something that these kids might not be able to describe, that the lights are bothersome and seeking other senses to help settle. So the brain is fascinating. I swear it can definitely, and it's so different in everyone. and just how these sensory systems link together. And if they're out of balance or out of whack, that can throw so many things off.
Yep, makes things fun.
Absolutely. Yeah, it's no two person is the same, and that keeps it interesting for us, that's for sure.
Yep.
And trying to help people and meet them where they're at and figure out where their symptoms are coming from, and then how we can help them and try to get them feeling and moving better. That's the point. Especially with kids, we want them to be able to get back to their sports, get back to their life, get back to their activities.
For
So
sure.
that's what we're here for. And I think it's a great topic that Fausta chose, because I feel like this is definitely underdiagnosed. I know
Yeah.
where I'm at in Brantford, there's a lot of parents that don't even know that their kids need to have physio after a concussion, or a local physician only, oh, it's 3 months later, maybe you should go get your concussion looked at, right? Like, it's so important that we keep talking about these things. So thank you so much for presenting, Fausta. And I think this is a topic we need to continue talking about and continue advocating for people as well.
Agreed.
100%.
Thank you, everyone.
Yes, thank you. If anyone has any last minute questions, let us know. We will send out the recording later this week if you missed anything. But yeah, thank you everyone for your engaging questions, and great job, Fausta. And and thank you everyone for hopping on.
Yeah. All right, amazing.
Awesome. Thanks everyone. Thanks, Fausta.
Thank you. I'm going to stop recording now.